Good morning, everybody. Good morning, colleagues. And welcome to the Early Childhood Systems, Perspectives, and Research webinar series. For those who are new to the space, this is a monthly initiative where we gather to share ideas, research, discuss all things early childhood development. And it's an initiative between Ilifa Labantwana, RESEP, which is Research on Socioeconomic Policy, and Data Drive. And today we've got another exciting conversation to have on the topic, measuring stunting and tracking trends in prevalence. We are looking at conceptual and methodological consideration with a focus on South Africa. This is based on the paper written, co-authored by Dr. Kate Rich, our presenter for this morning, co-authored with colleagues Liezel Engelbrecht, Gabrielle, and Ronelle Berger. And it's promising to be a really exciting conversation. Just a couple of housekeeping. We will have a moment for question and answers after the presentations. So if you have any burning questions, comments, or contribution to the conversation, you will be given an opportunity. Please raise your hand so we can acknowledge you. Alternatively, you can also make use of the question and answer box to pose your questions and comments, which we will engage with after the presentation. So just a couple of points from our presenter this morning. Dr. Kate Rich is currently a lecturer in economics at Wits University. Before then, she did a long stint at Stellenbosch University where she completed her PhD in economics and also did her postdoc with RESET, which is the Research on Socioeconomic Policy Unit. Previously, she worked at the HSRC, and she also has a really long standing interest in early childhood development, and obviously on the conversation this morning, which is around stunting. She's done many great things on early childhood development in South Africa, and her most notable recent one is her work with Grow Great on the Grow Great Community Stunting Survey. She has worked extensively with other large data sets and is interested on data quality and measurement. And so it is apt and appropriate that this morning she will give us a really interesting insight onto some of the conceptual limitation and methodological issues that comes when we are trying to track stunting and growth development in children broadly. So you are all duly welcome. And Dr. Kate, over to you. We're very excited to hear what you have for us this morning.
Okay, I've started sharing my screen. I just want to check that. Okay, you can see my title slide, right? Yes. Elizabeth, is it displaying correctly? I just want to check.
Yes, you're perfect.
Perfect. Okay, thank you. Thanks, Elizabeth, for the introduction. And yeah, thanks for having me. So yeah, you've introduced the topic already, so I'm just going to press on. So the first thing to note by way of introduction is that if you look at recent stunting estimates in South Africa, is over the last 15 years or so, 15, 16 years, they are highly variable. Right, so if you look at the colored dots, those are the colored dots with 95% confidence intervals. Those are the estimates from the various surveys that have collected data on stunting in South Africa since 2008. So the dots without labels are all the National Income Dynamics Study. The others are the Demographic and Health Survey. Very recently, or earlier this year, I think it was, the National Food and Nutrition Security Survey results were released. Those were all nationally representative surveys. I've also included here the Grow Great Community Stunting Survey and the Western Cape Stunting Baseline Study, which were both conducted in 2022. Those were not nationally representative. So the Grow Great study covered 7 of the most food insecure districts in South Africa, and obviously the Western Cape study only covered the Western Cape. So those results are not directly comparable, but I included them just for reference. The one thing I haven't included on this graph is the Thrive by 5 index data. So they also collected stunting data, but that was for children 50 to 59 months, if I remember the age range correctly. So that's also, which I'll get into in more detail later, that's not directly comparable to surveys covering the whole 0 to 59 month age range. So that's basically 0 to 5 years. So this black line here, sorry, I actually wanted to enable my pointer, laser pointer, there we go. So this black line here is the WHO, UNICEF, and World Bank joint child malnutrition estimates. It's basically a model incorporating estimates from nationally representative surveys. They include regional and country-specific time trends. They also take into account a country's socio-demographic index and the average health system access over the previous 5 years. And with that, they arrive at these estimates of stunting prevalence. So this is for South Africa from 2000 to 2022. You can see here that they estimate that stunting declined somewhat in South Africa between roughly 2006 and 2012. That broadly corresponds with the results of a 2015 paper by Said Mohammed et al., which they did a systematic review of the various stunting studies in South Africa up to that point. And they concluded that stunting declined between 2003 and 2013, I believe it was. So broadly speaking, it looks like there may have been a decline, but you can see here that the confidence intervals, so the uncertainty of these estimates is quite large. So yeah, we don't have very great certainty in these estimates because they only included a few survey data sources, because our surveys were fairly few and far between. You can also see that they actually excluded the NIDS wave 2 and 3 data, presumably due to data quality concerns. But the point here really is just that these estimates are sort of all over the place, basically. Do we really believe that between 2008, NIDS wave 1 and 2010, NIDS wave 2, stunting increased from about 25% to about 34%, or between waves 4 and 5 of NIDS. In between those years, there was the DHS conducted in 2016, and you can see the estimate jumps from roughly 21% in NIDS to 27% in the DHS. So do we believe these estimates? Is stunting really jumping around? I think not. It's something that's, I think, relatively slow to change over time. It's not the kind of variable where you would expect to see these jumps. So that's just by way of introduction and background. That was sort of the motivation for this, was trying to make sense of what can lead to these differences between surveys and affect comparability of estimates from different surveys. Firstly, I'm just quickly going to go over basically the conceptual limitations of stunting and the definition, what it does and does not measure. Then look at the age pattern of growth faltering and its implications for measuring stunting. And then finally, look at the various factors that can affect the comparability of stunting across surveys. So firstly, what stunting does and does not measure. So intuitively, stunting is being too short for one's age. But we measure this by if a child has a height for age Z score more than 2 standard deviations below the median of a reference population. And since 2006, when the WHO child growth standards came out, that has been used as the reference. So basically, if you fall below 2 standard deviations below the WHO growth standards median, you're regarded as stunted, and otherwise you're regarded as normal, basically, not stunted. So the first important point to make here is that this -2 standard deviations cutoff has no biological or clinical basis. It's essentially arbitrary. It's based on a statistical criteria that in a healthy population, you would expect roughly only 2.3% of children to fall below that cutoff. But the risks associated with stunting are unlikely to be much larger for children just below the cutoff than children just above it. So as your height for age goes down, the risks increase, but they don't jump around that cutoff, basically. So being short is associated with higher risk, and that does have a biological basis. It's just the cutoff itself that doesn't really have a biological or clinical basis. Stunting was also intended originally as a population rather than an individual measure. So now, it's quite common to use it as an individual measure. But the problem with that is that height for age Z scores and stunting don't measure one's individual growth potential. So I think, what we talk about stunting, I think what we're really interested in a way is linear growth faltering, which is a failure to reach one's own linear growth potential. So how you would have grown in a healthy environment. But unfortunately, we can't measure one's individual growth potential. We're stuck with comparing children to the median of the WHO standards. So the median would be here on the WHO standards at 0. We classify all children below -2 standard deviations as stunted, and others not. But we can't observe how you would have grown in a healthy environment. So a child just below the cutoff, who's regarded as stunted, maybe in a healthy environment, they would have been short anyway. Conversely, a child who's just above the cutoff, and we regard them as not stunted, they may, if they had been in a healthy environment, they might have had a much higher growth potential to begin with. They might have been really tall if they'd been in a healthy growth environment. So that child could actually be falling much further short of its growth potential, his or her growth potential, than a child than this child here, who is regarded as stunted. Unfortunately, we just can't measure growth potential at this point. As far as I know, no one's come up with a good way to measure it. So the implication of this is that stunting likely underestimates the true extent of growth faltering. A few authors have made the point that the whole height for age distribution, so this black line here indicates the distribution in lower and middle income countries, that whole distribution is shifted to the left of the WHO standards. So that implies that even children who are relatively tall are still below the WHO standard, which was created by studying basically healthy children in ideal growth environments in a range of countries. So yeah, even these children here are still falling short of the WHO standard on a population level. Okay, and then the final thing to note on just sort of definitions and issues with stunting conceptually is that stunting is a marker of a poor growth environment in early childhood, but it's not a direct cause of the various factors, the various outcomes that are associated with stunting. So stunting or linear growth faltering are all associated with impaired cognitive development, poorer schooling outcomes, lower wages in adulthood, higher risk of chronic disease. But stunting or just being short for one's age, whether it's measured by stunting or just your height for age Z-score, it doesn't directly cause any of those outcomes. Rather, a poor growth environment in early childhood causes stunting and causes those outcomes. So it's still a very useful marker, especially on the population level of how we're doing in terms of providing a good growth environment in early childhood. But it's just important to note that just fixing stunting in itself isn't automatically going to, fix early childhood development. Okay, so then the second part is just looking at how rates of growth faltering differ by age and the implications of that for measuring stunting. So there's a very clear age pattern in stunting and in height for age Z-scores. So height for age Z-scores tend to decline rapidly from birth to about 18 to 24 months. And then after that, they tend to improve. Similarly, with stunting rates, we see that stunting increases from birth to roughly 24 months and then levels out, and then it starts to decline. So among older children, 4 to 5 years old, it's actually lower than it is at 24 months. If you look at the SADHS 2016, the prevalence of stunting among children under 5, so the whole 0 to 5 age range, was 26%. But if you look at the peak prevalence, which was at 22 months, that was 36%. So stunting takes time to develop. Children below 24 months or 2 years are still becoming stunted. And yeah, I noticed this study by Chris Desmond and Daniela Casale from using the birth to 20 data. They showed that only a third of children who were stunted at 2 years were already stunted at 1 year of age. And then after 2 years, children may catch up from stunting. I say catch up because, in inverted commas, because there is quite a lot of debate about the definition and extent of catch-up growth. So Z-scores may improve, but even though your Z-scores improve after 24 months, absolute height deficits continue to accumulate after 2 years. It's basically to do with the definition of a Z-score, which is your absolute height deficit divided by the standard deviation from the WHO growth reference. And that standard deviation tends to increase with age, or does increase with age. So what that means is that a child who had the same absolute deficit at 2 years versus at 5 years would have shown an improvement in their Z-score, which we might see as catch-up growth, even though they were still the same amount too short, if that makes sense. The absolute height deficit didn't narrow at all. So as an example, if a girl was 7 centimeters too short at 2 years, this translates to a Z-score of -2.2. so she'd be regarded as stunted. If she was still 7 centimeters too short at 5 years, this would translate into a Z-score of -1.5. So she would no longer be regarded as stunted. And we might think she has caught up, even though the deficit hasn't narrowed at all. So that's the first point. The second point is that even if children do catch up, even if their absolute height deficit narrowed a little bit, there might be lasting consequences for brain development. So children who recovered from stunting by mid-childhood, this was also in birth to 20, they had better cognitive scores and schooling outcomes than those who remained stunted. So they did show some improvement, but they still did worse than children who were never stunted at all. So even if you catch up, there might still be lasting consequences for your development. And possibly, this is still, the jury is still out on this, I think, but unless you recover to a very large extent. But, you know, few children do recover to such a great extent. So in a nutshell, my point here is just that we might be underestimating the number of children who are affected by stunting at some point and who are still experiencing the lasting consequences of being stunted or of the poor growth environment that led to stunting, even though they've subsequently caught up. And we generally measure stunting by looking at the prevalence of stunting in children across the whole 0 to 5 age range. So that's including children who are still becoming stunted and children who have caught up but might still experience the consequences. Okay. So the last section, what affects comparability of stunting estimates across surveys? So the first thing follows on from what I've just discussed. If you have differing age distributions across surveys. Second factor is basically who is measured in your survey. And then measurement error can also inflate your estimates of stunting prevalence. And then various surveys have different methodological differences in how they, so what they measure, how they define implausible values, and those sorts of basically methodological differences. Okay, so firstly, differing age distributions. So basically, you can't compare surveys covering different age ranges because of this age pattern of growth faltering or stunting. Some surveys, like the National Income Dynamics Study, they didn't take height measurements of children under 6 months. So as children under 6 months tend to have a relatively lower stunting prevalence than children at 2 years, for instance. If you're excluding those children, then you might be overestimating stunting. But even if you do have exactly the same age range that you cover in your study, you might still end up with a different actual age distribution. So I had a look for this paper. There's a table comparing these recent South African stunting surveys, or I say stunting surveys, I mean, most of them weren't specifically aimed at measuring stunting. They measured a whole bunch of things, and height for age was one of them. But I compared these surveys in the paper, and well, actually, I mean, we did, it wasn't me in this case who did this, but it was Liezel made a really nice table comparing the different estimates, and you can see that basically younger children, so children under 1 year, seem to be a bit less likely to be sampled, and in most of the surveys, except the DHS, older children were also a little bit less likely to be sampled. So this is the Western Cape stunting baseline survey here. You can see here that children between 1 and 2 years of age were the most likely to be sampled, and children 0 to 1 and 4 to 5 were least likely to be sampled. So if you have different age distributions in your survey, that can affect the comparability of your estimates, because the risk of stunting differs so dramatically across the 0 to 5 age range. Okay, so then who is measured? I think this is one of the most problematic issues. So are children at home during the day? If you're conducting a household survey like NIDS or the DHS, then the field workers will go measure children at the household. If you're an older child, you're more likely to be away from home attending an ECD center when field workers come to visit. Children from more affluent households are more likely to be attending an ECD center and so not be measured. This was a point that I think was also made by Data Drive, and there was a really cool paper investigating the stunting data in the Thrive by 5 index, and they also made that point that basically who is being measured. If you're at home, you're much more likely to be measured. So I looked at the extent of missing height data across the surveys, and in the household surveys where they were targeted, they were measuring all the people in the household. They weren't specifically targeting children in these surveys. So that was NIDS and the DHS. In these surveys, large proportions of children who were successfully interviewed and they had data on other variables in the survey for the other questions, they had missing height data. So in NIDS wave 2, this was 50%. So 50% of children who were included in the survey had missing height data. In the surveys specifically focused on children, like Thrive by 5, the Western Cape Stunting Baseline Survey, and the Grow Great Community Stunting Survey, they all had much smaller proportions with missing height data. It's important to note that survey weights, so all of these surveys will include a survey weight, but these weights correct for the probability of being included in the survey, but they don't correct for the probability of having missing height data. So if your probability of being measured in the survey is related to something that affects your probability of being stunted, this can lead to serious bias in our estimates of stunting. So, for example, in the DHS, they helpfully put a table in the appendix of the DHS report on basically the characteristics of children with missing height data. And you can see here that among children whose mothers had no education, only 12% were missing height data. And 41% of children whose mothers had more than secondary education were missing height data. So basically, better off children were less likely to have their height measured. So therefore, we can't estimate we can't tell whether that child was stunted or not, and they don't make it into our stunting estimates. Similarly, with urban versus rural areas, children in urban areas were much less likely to be measured. Also, the more affluent provinces, Gauteng and the Western Cape, had much higher prevalence of missing data than the other provinces. So it does seem, at least looking at the DHS, that less affluent children were more likely to be measured. And because of that, we could be overestimating the prevalence of stunting. Then measurement error. Measurement error leads to more extreme values of height for age, and that can lead to an overestimation of stunting prevalence. So this graph is just comparing the standard deviations of the NIDS data in wave 3 and wave 4. So the standard deviation basically indicates how spread out the data is. So in NIDS wave 3, it was 1.9, which is very high, whereas in NIDS wave 4, it was 1.5. Basically, that suggests that NIDS wave 3 had a much higher measurement error than NIDS wave 4. And you can see that in the difference in stunting prevalence. So this is just a hypothetical based on a normal distribution, but if you look at the actual NIDS data, you see a similar pattern, that there's approximately a 5 percentage point difference in the stunting rate estimated from NIDS wave 3 and NIDS wave 4, and that's probably all due to measurement error, I would say, based on the fact that there appears to be much greater measurement error in NIDS wave 3. Okay, so basically, if the extent of measurement error differs across surveys, that can have a major effect on the comparability of those surveys. Okay, measurement error is more of a problem at younger ages because younger children are more difficult to measure. They have to be measured lying down below 2 years of age. And also a given measurement error translates into a bigger error in the Z scores for younger children. So the same centimeter difference, as I mentioned before, will be translated into a bigger Z score difference, for younger children. And older children are supposed to be measured standing, younger children are supposed to be measured lying down. That generally results in a difference of approximately 0.7 centimeters. But surveys don't always record this, how children were actually measured, so that one can adjust for that. So differences like that can all add up and lead to differences in stunting prevalence estimated in your survey. Then surveys differ in whether they adjust for gestational age. Basically, you can't compare a child born at 32 weeks to a child born at 40 weeks. They're not going to be the same height because their chronological age is not the same, or their age since conception. So surveys also differ in whether they collect gestational age data and then whether they adjust height for age Z scores for gestational age. So these methodological differences, they can lead to fairly small differences individually in estimated stunting prevalence, but if you put all of these small differences together, they can add up to quite a large difference in estimated stunting prevalence. Okay, other issues are how biologically implausible values are handled. So what cutoff is used. All of these factors can create differences between your surveys. So in conclusion, measurement error and under-measurement of children from more affluent households may inflate stunting rates. But stunting itself, as I mentioned in the first section, underestimates the extent of linear growth faltering. Overall, I would say, if you're interested in growth faltering, we're probably actually underestimating it. Particularly, given the graph showing how the entire population really is falling short of the WHO growth standards in most lower and middle income countries. Then, looking at children across the whole 0 to 5 age range, which is the standard practice, that may underestimate the number of children who are affected by stunting at some point in childhood with possibly lasting effects. But I think what we can say, despite the great variation in estimates that I showed on the first slide, we can say that at least in my opinion, we can say that too many South African children are stunted. So all the available estimates are much higher than what we would expect in a population facing healthy conditions for growth. According to all of the available estimates, around 1 in every 4 or 5 South African children is stunted, where in a healthy population, this would be 1 in 40. So I'm not saying we can't say anything about stunting in South Africa. If you're looking at estimating how many children are stunted at one point in time, then we can say, okay, well, it's way too high. But I think what we can't say easily is what has happened to stunting over time in South Africa. So because these estimates from these different surveys are not necessarily comparable, it makes it very difficult to track trends in stunting across time. And if we want to track progress towards reducing stunting in South Africa, which I think we do want to do and we should want to do, I think we need more regular nationally representative surveys that are using comparable methods and sampling strategies so that we end up with comparable estimates. Some possibilities include establishing a national nutrition surveillance system, or having the same survey repeated every few years, implemented by the same organization. These are just various ideas. How we implement this is, I'd be interested in hearing your thoughts on that. But yeah, I think overall, at the very least, we need, even if we don't have one of those two things, I think at the very least, we need more coordinated data collection efforts across organizations, so that, we're spending all this money on these surveys. They're incredibly expensive to run. And I think if we could all kind of agree on a uniform methodology to follow when collecting anthropometric data on children, then I think that would also go a long way to help. And also placing more emphasis on fieldworker training. Some surveys do, put a lot of emphasis on this, but I think others didn't as much, probably because of, the constraints of collecting massive surveys on a whole range of household variables. But yeah, I think fieldworker training and quality assurance during the data collection process is also very important. I just wanted to conclude with something a little bit more hopeful, saying that it is possible. If you look at Peru, they have conducted almost every year since about 2005, they have conducted the Peru Demographic and Family Health Survey, with a sample of nearly 8,000 children in every year. So this regular collection of data from the same survey allows us to say with a fairly high degree of certainty that Peru reduced stunting dramatically in the last couple of decades. If you compare this graph to the graph of estimates for South Africa, which looks a lot more like a dartboard if I was playing darts, because I'm pretty bad at darts. I think it just shows you what you can do if you have a concerted effort to sort of collect data on this indicator using the same methods and do it frequently. So yeah, I think it is possible to do it. I wouldn't say that Peru is particularly better resourced than South Africa. I think if we care about stunting, then, or linear growth faltering more broadly, then I think we should be looking at doing something like this. That is my, that is my opinion on the matter anyway. And yeah, thanks very much for coming. And I hope to hear some opinions on this.
Thank you, Dr. Kate Rich. That was very interesting indeed. I believe, well, by way of summary, what I gathered from the presentation is You are not saying, and this is for the researchers in the room, that we must throw away all these surveys and like just, forgo using them because of the measurement issues or the challenges that you have highlighted. I believe what you are saying is we need more data, but beyond the increase in data, we need quality data. So we need more quality to be able to track trends and to be able to measure this all important concept properly so that we make important policy recommendations that indeed will move the needle on addressing this developmental and public health challenge in the country. All right, so we will open the space for comments, engagement with what we have heard in the presentation and in the paper for those of us who have read. If you have a question, please put it in the question and answer box or raise your hand, and then we will address it as such. So I see we've got one question already. Come through, Dr. Kate.
Sorry, I just wanted to, based on what you said, I just wanted to reiterate that, I don't think that all of the stunting data that we have is useless. It depends what you want to do with it. If you want to look at correlates of stunting, for instance, all of these surveys collect various data on, households and parents and children and all of these things. And if that's your goal, you can do very useful things with it. It's just, we've got to bear this bias in mind. And I think it's particularly problematic when you're trying to track trends in time, basically. Yeah. But yeah, just to say, I'm not saying it's not valuable data. It's very valuable, just not for tracking trends. Yeah.
Perfect. So we will take a question from Gabrielle. I've noticed your hands. Please ask your question.
Hi.
Okay.
Thanks so much, Kate. That was really clear. I think the question I have is for people that are wanting to, or groups or organizations that are wanting to measure stunting, do you think that, just leaving it to hopefully people will choose the right methodology and implement a standardized way of doing this, I think is perhaps not the best approach. And if one were to say, well, where best could there be some level of accountability or coordination for this type of thing, so that if a person, if a group or an organization or individuals take on measuring stunting, that first of all it's known about. So almost if there's some kind of like coordinating place. So let's say, for example, if you were to submit a pre-analysis plan for a randomized control trial, for example, do you think that it would work to have something like that where people have to engage with the body so that you can really make sure that there's some kind of standardization around the method, the sampling, with which this is done?
I think that's a really good and interesting idea, actually. I don't know, I don't know what organization would take that on, but as you say, there's various sites where you can register randomized controlled trials. So if we had something similar, that I think that could work. But I think, there is already sort of some guidance out there from UNICEF. So they do have a document out there, quite a long, extensive document on basically how to collect and analyze stunting data or anthropometric data in general. But I think, a lot of organizations, I didn't know about it until I started looking into this, actually, then I found this document and it's got all these long, guidelines, but I think maybe a lot of people don't know about those guidelines. So I think if everyone could kind of agree to follow, okay, we're all going to follow these UNICEF guidelines, I think that would go some way to helping to addressing this. But yeah, I don't know I don't know what organization would kind of take on the the role. Oh, Liezel says perhaps human research ethics bodies. Yeah, I mean, maybe there is scope for. I mean, I don't think we want to be like policing researchers, but I do think that ideally, you know, given the amount of money that is spent on these surveys, I do think that there is some responsibility for us to try and make the data that we get from these surveys as useful as possible. So yeah, I think there could be scope for something like that. Having, you know, somewhere, I don't know who should do it though. I don't know who should be responsible for that. Yeah.
All right. We've got a question from Lisanne Duplessis, and she is saying that for public health nutrition purposes, she agrees that there needs to be a range or a combination of indicators. So perhaps a stunting scorecard for use at provincial level. This is something that she herself is busy with on a project. And she wants to know that the WHA's target for stunting reduction focus on 0 to 5 years, 5-year-old children. It may be more useful to change the target to measuring and reducing stunting in 0 to 24. So I think her question points to one of the issues that you were raising about the range for the children in the specific surveys that we've also been looking at. So do you think, I believe your question is saying, do you think we should change the target to much younger, 0 to 24, as opposed to looking at the entire 0 to 5 range?
So I think it is tricky. Yeah, thanks, Lisanne, for the comment. I think the practicalities of sampling make it a little bit tricky, unfortunately. I think ideally, it would, you know, if we could measure children at 2 years of age, that would be great. You know, when they reach 24 months, are they stunted or not? Then I think that would give us a much more accurate picture, hypothetically, of, you know, basically how many children are stunted at the age of peak risk. But the practicalities of sampling, you know, it's much easier to kind of go out and find a sample of children under 5 than maybe if you do it under 2, that might help. But you know, to kind of isolate it to a narrower age range, I think might be tricky from just a sampling perspective and in terms of survey costs and that kind of thing. I think, you know, one thing, and I think, you know, Lisanne's been involved in work on the Road to Health card. And I think if we had confidence that that data was accurate, you know, I think that could be a useful source of data. But unfortunately, I think some of Lisanne's work has shown, I hope I'm not misrepresenting it, Lisanne, but that a lot of children, even though they're supposed to be measured in the clinic, aren't measured. And then beyond that, there's a lot of measurement error in that data as well. So yeah, that unfortunately, I think is not a solution at this point. But yeah, if we can come up with better ways of measuring children, that, you know, I think watch Lisanne's work for that. I think that would be helpful as well. But yeah, I just think maybe we should focus on children 0 to 2, but if we try to narrow it down further, it just can become very tricky in terms of sampling. Yeah.
All right. Thank you. I'm just looking out. Are there any more burning questions or comments from the audience? All right. So maybe the last question, and I'll abuse my position and ask mine. Is so given the measurement and challenges you have discussed in the presentation and also highlighted in the paper, So how should policymakers then interpret some of these data, or there is information or research that looks or tries to compare stunting or tries to draw, stunting prevalence using these different tools to raise the issue of the need to address it to obviously meet developmental goals? So how must policymakers interpret the data?
Unfortunately, I have to say, I think with great suspicion, if you're talking about looking at trends, to look at this graph that I showed in the beginning, I don't think I need to share it again. I think everyone's seen it already. If you look at that graph and conclude that stunting went up between 2010 and 2011 by 7 percentage points, and then just decreased again by another 6 percentage points the next year, I think you should interpret that kind of thing with great caution. I think I have actually seen in reports as well, people talking about, oh, well, there was a decline, we're comparing our data to the Sanahan's data or whatever, and we see a decline in stunting. I think we should be very wary of making those kind of claims and suspicious of those sorts of claims, unfortunately. But yeah, as I said, I don't think all of the data we have is useless. It's not useless to policymakers. I think that we do. I think we can say that stunting is too high, basically. As I said, 1 in 4 or 1 in 5 children is stunted in South Africa. In a healthy population, this would be 1 in 40. So, I think what you can take from all the data is that we need to prioritize reducing stunting in South Africa. But if we want to track our progress towards doing that, then we do need to, I think, invest in gathering comparable data across time. There were a couple of questions in the chat I saw. Yeah, I agree, Liezel, about needing real-time data. Yeah, I think you're probably best placed to, kind of point the way forward on that. But yeah, I agree. If we could get that would be great.
Perhaps for being mindful of time, we could end with Gabby's comment/question on the extent to which the DHS process is standardized, keeping in mind that the SDG 2.2 is about reducing stunting, and it requires some sort of standardization in measurement.
Yeah, I think I agree.
Food for thought.
To what extent is the DHS process standardized? I think that is, as far as I could tell, that is pretty standardized across countries. But there are still kind of differences, looking at South Africa compared to other countries that have undertaken the DHS. Our sample size was really small in comparison of children with valid height for age Z scores. So, that does make me wonder what went on there. It makes me wonder if something strange happened in the South African DHS compared to other countries' DHS surveys. So, yeah, I think even if it's tricky, even if the process is standardized, sometimes on the ground things go wrong. But yeah,
thank you so much. So the take-home message for today is that stunting survey data is not completely useless. We need to engage with it with care, and we need more reliable quality data to be able to track trends over time. Thank you very much, Dr. Rich. And for colleagues who are in the chat who are interested further conversation outside of this space, you can reach out to her. I'm sure she'll be happy to engage with you on ways to obviously improve stunting information in the country to obviously get what we are looking at, reducing stunting. So our next webinar series, it will be on 2nd of October, and we will be looking at a very interesting aspect of early childhood care and education. It will be by Dr. Edrich Moses from RECEP, and same time, same place, 2nd of October. Please look out for the flyers, register, sign up, and we will meet again in a couple of weeks to have another engaging discussion. Till then, keep well. Have a good day.
Thank you very much. Thanks, Elizabeth, for hosting, and yeah, thanks for all the interesting discussion.